Probably, I would say, just talking to people at our meeting last week, there was some discussion, is there a screening window for ocrelizumab? And we really don't know. Like I said, in relapsing forms of MS, we now know, because there's been some studies, that the earlier you treat the patient, the better their response. And we don't have that kind of study yet in PPMS. My opinion is treat them immediately. But on the other hand, sometimes it takes a couple of years to diagnose that person, because that person might start out looking like relapsing MS, but then suddenly start progressing, and there is no cutoff, say, aha, progressive MS. So it's sometimes very difficult to be able to say from the day one that person's going to have a progressive course. They treat everybody like relapsing. And I'm hoping that there may be some biomarker, which they're looking into now, to see if maybe the light chains may be more predictive of progression, or maybe sometime like a blood test, or maybe some spinal fluid indicators, something that'll say this person's not relapsing, get them on something for progression. We don't have that yet. That's exactly. They treat all MS like MS, and they treat it as if it's inflammatory. And one of the other things we learned, I guess about 10 years ago, everybody always said that people with PPMS never had enhancing lesions. There was a study called the PROMISE trial with Copaxone, and that trial showed, when they did MRIs, that these people with PPMS had enhancing lesions. So of course, if you have an enhancing lesion at time of diagnosis, you treat them like they belong on the DMT for inflammatory disease. So again, I think biomarkers are going to be the real answer on how to differentiate between active and inactive, and PPMS versus relapsing form.